Okay, I'm going to get started. Welcome. Thank you all for joining. My name is Alan Schroeder. I'm the co-chair of this weekly seminar series, along with Dr. Rajni Matthew from Infectious Disease. I'm from Hospital Medicine and Critical Care. We have an exciting session today, kind of, I think, the first really a case-based session. We've had several prior talks where cases have been presented, but this one's really going to revolve around a case. And Dr. Matthew will be the moderator of that session and introduce our speakers in a bit. Upcoming sessions, a really exciting one next week, where we're going to bring in a couple of subspecialists from outside the department to talk about some of the organ systems and involvement of those organ systems that we haven't addressed yet. We'll look at some of the dermatologic manifestations of COVID. We'll look at specifically for ENT, we'll look at some of the anosmia and dysgeusia complaints and symptoms that folks are having and see the extent to which we're seeing that in children. And then we'll also focus on eyes, and there the issue is going to be all of the screen time from remote learning and probably on top of that, just excessive screen time in general outside of school and the degree to which that might impact the developing eye. And then after that, on the 28th, Grace Lee will be back. A very hot topic, of course, is vaccination. We're hearing about that from all sorts of venues, but we're not hearing a lot about the pediatric angle. Grace, all you have to do is pick up a newspaper and see Grace's name about having really anything having to do with vaccination of adults or kids. So she's been central to these efforts and will come back and update us. In the meantime, you can stop sharing, Ingrid, and we'll move on with today's session. We'll start as we usually do with a trainee quick hit. Today we have Jen Sequoia, one of our second-year physician scientist residents, who is going to be going into neonatology. Is going to talk about this article that was just published this week in JAMA Pediatrics. Take it away, Jen.
Hi, thanks, Alan. It's a pleasure to be with you all today. So I'm going to be talking about this research letter from earlier this week in JAMA Pediatrics. This was put out by a management science group out of University of Minnesota, trying to answer the question of how have the rates of hospitalization for COVID-19 in pediatrics changed over time. And this is really with an eye towards resource planning. So this was a cross-sectional analysis using data from the University of Minnesota COVID-19 hospitalization tracking project, as well as the US Census Bureau. And from this data, the group looked at 22 states that specifically segregated out data for people under the age of 19 in most states, but then some of the states reported under 17 or under 14 as their cutoffs. The data was collected between May and November, and based on this, the census data, they calculated the rate of hospitalization of those patients with COVID-19 per 100,000 patients or people over time in each state. And so this is a little bit of look about how they put together the data. So this is just a sampling of 5 of the states. They looked at the cumulative hospitalizations for all age groups, and then those specifically for pediatrics. And then they compared at the beginning, so when they started looking at the data in May, to the end. For this is, again, the rate per 100,000 people. And then they looked at the growth, so comparing the growth for pediatrics versus adults. What they found, so in the 22 states during the study period, they found that the total hospitalizations was about 300,000, and pediatric specific group was 5,364. And then looking over time, the average cumulative hospitalization rate was 2.0 per 100,000 children at the beginning of the study. And then at the end of the study, the average across the states had increased to 17.2 per 100,000 children. They noticed that there was a wide variation across the states And then they also noted that their growth in pediatric hospitalization over the study period outpaces the increase in the adult hospitalization. So that's looking at these numbers here. So for Arizona, 4,000 versus 1,248. The conclusions that they drew from this data is that the pediatric populations may require resources that are not readily available across the country, and that the hospitalization growth may offer reasons for concern around in-person education. So I think one of the key limitations for this study is really in their definition of COVID-19 hospitalizations. So there's a difference between children who are hospitalized with COVID-19 and those that are hospitalized because of COVID-19. And so this is getting at where they got the data from. So the University of Minnesota COVID-19 hospitalization tracking data comes directly from the HHS. So I pulled out the guidance from HHS to hospitals for reporting COVID-19. And so this is what they say for reporting pediatrics. For the subset of hospitalized pediatric confirmed positive COVID-19 patients, that's all patients currently hospitalized in a pediatric inpatient bed, including NICU, PICU, newborn, nursery, who have laboratory confirmed COVID-19. It does not say that they were admitted for that reason. It's just, do they have the disease and are they admitted? So saying that, I think what we see is that in adults, we know that COVID-19 is driving a lot of these increased hospitalizations, and that is the primary reason for admission. But here at LPCH, what we've noticed is that a lot of the kids that have COVID-19 are really being admitted for other reasons. And in order to better address the question of whether the COVID-19 is the cause of the hospitalization, you could use something like billing data to look at what the principal problem for admission is, to really narrow down and specifically look at the cases of COVID-19 driven hospital admissions. And I think that would be more specific to the question that they're trying to answer. And then one final point about the this increased growth from the in pediatrics versus adults. I think that we can attribute to increased testing of kids during this time period, because as the pandemic's gone on, we've really come to appreciate that kids are asymptomatic, and it's become the norm in places, here included, to screen on admission. So kids who are being admitted for any reason are being screened. And so I think those are the two main points I wanted to make, that that we're not necessarily seeing an increase in COVID-driven admissions in pediatrics, and that these increased rates of COVID-positive patients is really probably reflecting more community prevalence. Okay.
Terrific. Did you have another slide? Or was that
That's it.
Okay, thank you so much. And you can, if you don't mind, unsharing your screen. That was great, Dr. Sequoia. And yeah, to just emphasize, over half of our patients here at Stanford have been patients who were hospitalized, that are COVID positive, were hospitalized for reasons that had nothing to do with COVID. So really cautious about interpreting pediatric hospitalization rates. And thank you for emphasizing those points. Dr. Matthew, off to you.
Thank you so much, Dr. Schroeder. Today's session is going to be on MISC, and we have an excellent panel of multiple specialties here today, and I just want to briefly introduce them before I start sharing the case. Dr. Guillermo De Angulo is a clinical assistant professor in emergency medicine at Stanford. He completed his fellowship in New York University Bellevue Hospital in 2019, at a time when New York was the epicenter of the pandemic. So he will bring that perspective to this discussion. Dr. Saraswati Kache is a clinical professor in pediatric intensive care at Stanford. She's part of Stanford Medicine's Global Health Program. She's also the medical director for transport for the PICU here. Dr. Hayden Schwenk is a clinical associate professor in pediatric infectious disease, and he's the director of the Antimicrobial Stewardship Program at LPCH. Dr. Kache and Dr. Schwenk co-led the MISC pathway creation here at LPCH and involved a multidisciplinary team, some of whom are here with us in the panel today. Dr. Dana Gerstbacher is a clinical assistant professor in pediatric rheumatology at Stanford. She works in the integrated medicine clinic here as well. And last but not least, Dr. Seda Tierney is an associate professor in pediatric cardiology, and she is the director of the research in non-invasive imaging laboratory and director of the Pediatric Vascular Research Laboratory at LPCH. So I want to thank each of our panelists, and obviously Dr. Schroeder can bring in the hospitalist point of view. He's also an intensivist, so I think we have most of our bases at least covered at this time. So I'm going to share the screen, share my screen right now to share our case. So I just wanted to start off by giving a little bit of a case definition and a background to MISC. So most of us know the case definition, but just to once again go over the CDC's definition. As you know, there is a WHO definition and the Royal College definition from England as well. The CDC definition is less than 21 years, a patient presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multiple, so more than 2 organ system involvement, no alternate plausible diagnosis, and positive for current or recent SARS-CoV-2 infection by RT-PCR, serology, or antigen test. The fever is defined as more than 38 degrees for more than 24 hours. And there are multiple laboratory parameters that can, that is consistent with laboratory evidence of inflammation. And this is a reportable illness to the Department of Public Health. To also talk about the current epidemiology. So the total number of MISC cases so far reported and captured by CDC is 1,659 with 26 deaths. Just to put also the whole number of cases in pediatrics in the United States, it's 2,299,000 cases. So that's about 3,055 cases per 100,000 children in the population. So the 1,659 represents about 0.7% of this total number of infections. This is the 7-day moving average from CDC till the end of last year. And in terms of age groups, so this is what has been interesting is there are several features of MISC that are similar to Kawasaki, but what has been striking since the beginning is the age group. As you know, Kawasaki impacts less than 5 years of age, but if you can look at MISC, the majority of cases have been over 5 years of age. And in terms of race and ethnicity, again, there is a disparity there with large number of Hispanic and Black Americans more affected than the rest of the population. So I would like to move on to the case now, and we will present in such a way that all of our panelists will get an opportunity to weigh in at different points as we go along. So this is a patient that was that had a stay at LPCH, but had part of his stay at an outside hospital. So I'll begin from the outside hospital. This is a 12-year-old previously healthy male. He tested positive for SARS-CoV-2 in early October. Since that time, though, he has not felt much better. So he continued to have intermittent fevers, frontal headaches, and diarrhea. Multiple family members also tested positive along with him, but all of them recovered. He presented to the local emergency department 4 weeks after his original diagnosis in November 2020. That's 4 weeks after his diagnosis, with persistent fevers, now higher grades at 104 degrees, nausea and diarrhea for 4 days. These were some of the laboratories that were obtained in the outside emergency department. So this is the CBCD and complete metabolic panel and ProCal, and I will highlight some of the abnormalities. So all of these abnormalities are not severe, but they were definitely slightly abnormal, like the white count, slight leukopenia, some thrombocytopenia, hyponatremia. There is mild elevation of AST, ALT, and an elevation of ProCal. His repeat SARS-CoV-2 swab was positive. He had a flu A/B done that was negative and a monospot done that was negative. So I want to pause here for a minute and have Dr. De Angulo just share his thoughts about what goes through his mind as an ED physician. And I know that we have all had an opportunity to scan through this particular patient's chart to weigh in. So if you have any thoughts on this patient or in general, what are your thoughts at this point when you see a child coming in with fever and persistent symptoms 4 weeks after diagnosis of COVID?
Well, I think the first thing is, with the time of COVID, we can't forget the other diagnoses as well. So while COVID is on our mindset and MIC is potentially also as well on our differential, we can't forget potentially other diagnoses. So influenza, good thing that they test for that. Does the patient have an acute gastroenteritis for unknown reasons? Does he have appendicitis? So we have to remember to keep our differential pretty wide in these patients as well, because it'll be very easy just to kind of pigeonhole ourselves into this is COVID and forget or miss something. And that's kind of has been the trick in the ED at this time, is really trying to focus on COVID and not missing that, but at the same time not missing some of these other diagnoses. So I think what this outside ED did was actually pretty appropriate. The patient presented there had, for these symptoms of fevers for 4 days, some headaches, some cough, some abdominal pain, and they actually kept a pretty wide differential from reading their notes. They did a blood work. They did, I think, a chest X-ray that was negative, an ultrasound of the abdomen that also was negative as well. And they treated his fever, and the kid looked great, apparently. Vital signs were never abnormal other than some tachycardia while febrile, and he actually was discharged home at that point. But I think the key for this kid being discharged home at that point was that the ED physician actually called his pediatrician and spoke with this pediatrician to establish a close follow-up with this patient, knowing that there might be something going on there, but he was not sick enough to be admitted at that point. So I think that was a big key. And it was because of that close follow-up that actually the kid had to return back to the ED soon afterwards. And even then, at that point, with the repeat workup, his transaminitis was still a little bit elevated. His procalcitonin was still high, and I think his ESR was also elevated at that point. But it was at that point that his hypotension is actually what showed up and what really led to the diagnosis at that point, I think. So when I see a patient like this in the ED, the biggest thing is, hey, first keep a big differential, but also having that close return precautions. And if you're going to discharge them home, or depending on your threshold, how much do you want to just admit for observation, see how the kid does, and potentially discharge them after that.
Thank you so much, Dr. De Angulo. I think as general pediatricians and ER physicians, I think this is the hardest decision, is whether this patient will get worse, or the question about, can we discharge the patient? Do we admit the patient? I think these are very, and how far along to go, how far to pursue workup. I think these are very tricky decisions. So I appreciate your input.
While she's doing that, if there are general, we have a great audience today. If there are general pediatricians in the audience that want to enter in to the Q&A, some of their questions or experiences, because we're an inpatient, this is an inpatient case, but obviously I think a lot of pediatricians are fielding concerns about this and potential cardiac involvement. So feel free, please, to enter some of your perspectives in the Q&A.
So the patient was admitted, as Dr. De Angulo was mentioning, because of hypotension and fluid hydration status issues, was admitted at the outside hospital, continued on fluids, And he was also started on ceftriaxone and remained on it while at the outside hospital. Throughout his admission, which ranged about 3 days there, he ran blood pressures 80 to 102 over 38 to 62. He received multiple fluid boluses for hypotension episodes prior to transfer to LPCH. During his hospitalization, he remained febrile. He was also noted to have hematuria and proteinuria. Just prior to transfer to LPCH, he was started on norepinephrine and also received a dose of methylprednisolone. These were his labs at the time of transfer. So just some degree of hyponatremia, hypokalemia, as well as some decline in his albumin, which was previously normal. But to the left side, you can see all the other markers that are have now become the MISC kind of second tier laboratories that were all also abnormal: ferritin, BNP, troponin, ESR, LDH, and D-dimer. These were all abnormal at this point. And then he also had an EBV serology panel that was negative, mycoplasma, IgG, IgM negative. His stool cultures by this point had come back negative. He had blood cultures ×2 that were negative. Briefly, his past family and social history, exposure history, so nothing too significant. He's a previously healthy child. He has no history of autoimmune diseases in his family members. And he lives with his parents and siblings, all had COVID towards the end of September and October. There are no pets at home, no travel recently, no international travel ever. He was admitted at our pediatric ICU, and actually Dr. Kache was the admitting physician, she can talk more about this. The initial assessment, which I copied from the chart, was that there was strong concern for MISC given the presentation 4 weeks after COVID diagnosis and particularly his hypotension. And they were planning to do EKG, echo, troponins Q6 hours, and obtain the different consultations per our MISC pathway. And he continued on norepinephrine. At this point, the admission labs at LPCH. So you can see the CBC is largely fine, actually. So there's no more leukopenia or thrombocytopenia. His ESR is elevated at 61. You can see the coagulation numbers are also abnormal. D-dimer is abnormal, and his fibrinogen is elevated. And towards the bottom of the right-hand side, there's the troponin, ferritin, and pro-BNP numbers that are elevated as well. So at this point, I want to pause again and let Dr. Kache just share her thoughts about this patient, and in general, as an ICU physician who is seeing this patient, what are some of the things that come to your mind as you're trying to diagnose and manage this patient?
Yeah, thank you, Dr. Matthew and Dr. Schroeder, for putting this together and inviting me to speak about this patient. I have to say, first thing is to give a ton of credit to the general pediatrician that transferred the patient to us from the referring institution, because the truth is that she actually was the one managing this patient for 3 to 4 days in the outside hospital on the floor, and was the one that thought of the diagnosis of MISC and reached out to us and had said, hey, we have a patient that has been persistently febrile for 4 days without a clear infectious etiology and isn't improving. And I think one thing to note was that he progressively started to have hemodynamic decompensation, and that initially he would respond to the fluid boluses that they were giving him, but then became progressively more hypotensive. So on that last day, the fact that he was continuing to be febrile without any signs of improvement despite treatment for his infection, the history of COVID, and the hemodynamic instability all sort of triggered the general pediatrician to transfer the patient, or at least to think about MISC and to consider transfer to us. When our transport team had arrived, the patient was definitely hypotensive with blood pressures of 80s over 40s, tachycardic, neurologically intact, and at that time had a PIV in place. And so along with giving another fluid bolus, we chose to start the patient on norepinephrine through the peripheral IV that he had in place, which we can certainly do for a given period of time, and don't need to have central access in place, because I know this is a question that often comes up of like, can we do inotropes through a PIV? And he actually, at about a moderate dose, I would say, of norepinephrine, had hemodynamic stability. And then in reviewing his labs that were discussed with the pediatrician and sort of his overall hospital course, we decided that he did meet the criteria for MISC, and the transport team actually went ahead and started him on the Solumedrol. And I know that you're going to be talking a little bit more about the MISC pathway and the treatment recommendations. And then upon his arrival here, had the rest of his workup done as well of evaluating his cardiac function. We continued to monitor his labs, administer IVIG. And he actually had a very nice recovery over the course of the next 24 hours. So I think in my mind, sort of the big things that stand out for all of us as pediatricians. First is that, you know, really kudos to the general pediatrician for thinking of the diagnosis and for transferring the patient to us in a timely fashion. And that at least so far, it seems that the treatments that we have been administering these patients have been effective, or was effective in this patient, or that we were able to administer and move his course forward. So.
Thank you, Dr. Kache. That's super helpful. I'm going to try again. Hopefully this time. Okay, so this patient underwent some an EKG as well as an echocardiogram. This was his cardiac evaluation at this point. And I just want to pause there and get Dr. Tierney's input, because I know that you have seen this patient as well. And so you have an insight into this specific patient. But in general, I feel like suddenly we, as non-cardiologists, are getting a lot of information on cardiac labs. And so trying to figure how that helps inform your decisions on MISC versus not.
Thank you. Thanks also for inviting me. I actually got to meet this patient as an outpatient, and he said once he was hospitalized and was under care, he felt like a new person. So he was able to express that himself. So the data on cardiovascular involvement in COVID and Misc are still obviously evolving. We think the etiology is multifactorial and includes cardiomyocyte invasion, inflammation, and endothelial injury. And how does this manifest? So the one thing is cardiac dysfunction, which is the most common finding as well. The other findings are coronary artery dilation and aneurysms, which we were looking at in our, as you can see in our echo report, and as well as arrhythmia and conduction abnormalities. So the cardiac dysfunction is actually fairly common, and it's been reported in up to 50 to 60% of cases with Misc, and it's more likely to be present in patients who actually present in shock. They are at the highest risk. Thankfully, our patient never had any cardiac dysfunction. Elevated troponin and BNP levels, as you actually went through, are also fairly common. And in our patient, it was transiently elevated. So that's another thing to look at. And in terms of coronary artery dilation and aneurysms, The reports are varying, but the larger series have reported up to 24% of patients with Misc having some coronary artery changes, depending on how you define it. We define coronary artery aneurysms as aneurysms once they reach a Z-score of more than 2.5 based on their BSA. And most of these reports, they have been small aneurysms, but there have been a few patients who actually had large or giant coronary artery aneurysms where they needed more frequent reporting, monitoring. And in our patient again, on serial echoes, we did not see any coronary artery changes. And finally, there could be conduction abnormalities or arrhythmias in Misc patients. The incidence is still not that well known because we are just collecting data. In adults with severe symptoms, both atrial and ventricular tachycardia has been reported. And in Misc cases, the most common EKG findings have been atrioventricular conduction delay, specifically first-degree heart block, as in our patient. The good news is that most of these findings resolve in time, but they need close monitoring. I guess that will be my most important piece. When there are changes, it's important to serially monitor both for coronary artery aneurysms as well for as EKG changes. And the other thing to remember is the coronary artery changes can happen during the convalescence period. So it's important to actually have a repeat echocardiogram once they are discharged. So, thank you.
So now we'll move to Dr. Schwenk. So as ID physicians, we get consulted very quickly on these patients with MISC. And I know that you have had experience taking care of other patients as well. So would love to hear your thoughts as you consult on patients such as this patient. What are some of the things that are going through your mind? And if you can share your experience.
Yeah, absolutely. And thank you again for the opportunity to join you this afternoon. So I think this particular patient, to just start with a couple of specifics, had some features that would push me in the direction of concern for Misc. I think the presentation with prominent GI symptoms is something that we have seen in several of our Misc patients and seems to be a relatively common presentation among those patients. There were also some clues in the labs that you pointed out earlier that look to be consistent for a patient with Misc. One that wasn't pointed out, but I think we've also noticed is lymphopenia. We've noticed that many of these patients have a very low absolute lymphocyte count. Interestingly, this patient's lymphocyte count was low at initial presentation, but did appear to normalize, I think, by the time they were transferred to Packard. And then obviously we have the epidemiologic history, right, which I think for an infectious disease physician is really critical, right? We have the information in hand that this patient has a history of SARS-CoV-2 infection. And I absolutely agree that we need to keep a broad differential. You can have a SARS-CoV-2 infection, as has already been mentioned, and develop other infectious issues outside of Misc. And so I think it's entirely appropriate to keep the differential really, really broad. I think one of the questions we get commonly is the antimicrobial management, and this may be something you get to later, but just to kind of set the stage, I think, you know, if you have a patient who is presenting to the ICU in shock, it's really difficult up front to be certain that a patient does or does not have septic shock, right? I think we have a lot of things that favor a diagnosis of Misc, but I also feel like in a patient who's an extremis on inotropic support, where the picture, you know, is not going to be immediately clear, and we'll take some data, including the microbiologic data like the blood cultures, that it's entirely appropriate to start empiric antibiotics in that setting. Wearing my antimicrobial stewardship hat, I think it's critically important to reevaluate the ongoing need for those antibiotics on a daily basis. You know, as the microbiologic data, as the additional data become available, I think you can reassess the need for the ongoing antibiotics at that point. I do think there's also common infectious diseases that can look very similar to Misc, right? So things like toxic shock syndrome. And then interestingly, there was a case series in hospital pediatrics recently with a series of patients, I think from Texas Children's, who had murine typhus, which was really, really interesting. Not a diagnosis we see a ton of in the Bay Area, but just to say, you know, it's critically important to keep the differential broad, both infectious and non-infectious. But I think when you're presented with a patient like this, it's appropriate to start even your treatments broadly, and then based on the data that becomes available, modify accordingly.
Thank you, Dr. Schwenk. And if you want to add on the use or a need for remdesivir or any other targeted antiviral, if you can share that as well.
Yeah, absolutely. The fact that I omitted it probably suggests how I feel about it. So there has been a lot of discussion about the utility of remdesivir, and I think we have to take a step back and ask ourselves, what is the pathophysiology and what is the process that is occurring, and where are we in the stage of illness when someone presents with Misc? We believe this to be a sequelae of SARS-CoV-2 infection, but it's probably not in and of itself being driven by that infection. Most of the patients who are presenting are coming quite late after their acute COVID infection. And so how much of what is happening in that moment when you present with Misc is due to the virus versus the body's response to the virus, right? And we think that with most of the modalities that have been successful, things like IVIG steroids and other treatments, which I'm sure will be discussed later, those are all really working on the immunologic response rather than the virus itself. Now, if I was presented with a patient who was still PCR positive, and we could talk a little bit about, the significance of a PCR and the serology, who also had prominent respiratory symptoms, and who was critically ill, I think it's a very fair question to ask what the added utility of remdesivir or directed antiviral therapy would be in that setting. I'd say that this is an unresolved question, and from talking to colleagues across the country, there are certain centers where if it's consistent with Misc, under almost no circumstance, including PCR positivity or respiratory symptoms, would they give remdesivir? And then I've talked to other centers where they're a little bit more liberal with it. It does also bring up an important point, which is that, a lot of what's described in terms of respiratory symptoms, which Dr. Kache can talk more about, is actually related to fluid resuscitation and not viral infection itself. And so it's sometimes difficult to tease that apart. But some of what we're seeing in terms of the, respiratory symptoms may not actually be due to infection, but the resuscitation the patient received.
So Dr. Gerstbacher, so at this point, we are going to consult you as well, because the ID doctor, the cardiologists have already seen the patient, and at this point, everyone's feeling strongly that this is MISC. So when you come in to see the patient, what are the thoughts you consider, and your thoughts about management as well?
Yeah, so thank you for inviting me today. This particular patient, I think when you start to see uncontrolled inflammation, hypotension, shock, you want to follow those labs pretty carefully. But for this particular patient, he had a really lovely response to initial measures, got IVIG, got methylprednisolone, and his labs were already starting to improve. He clinically was feeling significantly better. And so we didn't need to give him additional immunosuppression. But I think that that's always the question on our minds is, if we're seeing ongoing inflammation, how do we get it quiet as quickly and safely as possible? And I think, what we've been using most commonly is anakinra, IL-1 receptor antagonist, which works nicely for some of the kids who are resistant to initial management with IVIG and steroids.
And how long do you give the child to respond to IVIG and methylpred?
Yeah, I think it also depends on their overall clinical status, and if they're getting worse in other regards, then we would move more quickly. But usually like 24 to 48 hours after initial treatment to look for the response, both clinically and in the labs.
Thank you all. And I just will share the patient course at this point. So this is a snapshot of our pathway that we have at LPCH. And this patient fell in this category of moderate MISC based on the definitions of criteria, mild or single organ injury. This patient did have vasoactive support, so the patient fell under this. The patient did not fall under the severe category. And if anyone has any input, please feel free to add. At this point, the patient did receive the methylpred and the IVIG at 2 grams per kg. We will talk about aspirin and would love your thoughts on the aspirin as well, but this patient did not go on to receive anakinra. And actually did very well after that and was discharged home. And perhaps Dr. Tierney and Dr. Gerstbacher, if you could describe to us a little bit about his outpatient progress, and we can then share the other questions.
Yeah, I did see him in the outpatient clinic, and he was doing really well. He felt really good. His echocardiogram again looked normal. So I released him, asking him to come back one more time. He's not a very active child. Actually, this is something we should probably mention. He's also, he has a high BMI, which is a risk factor for kids for Misc. So I asked him to, I told him that he could do his regular activities, but obviously there would be other considerations if he was a physically active child or if he was an athlete in terms of having him return to his regular sports activities.
Dr. Gerstbacher?
He didn't have echo abnormalities, and so he didn't receive aspirin. In the outpatient clinic, I think his labs normalized pretty quickly, and so we discharged him from further follow-up care.
I know we are getting a few questions and we will get to them shortly. Dr. De Angulo, I would like to get a few thoughts from you about your experience prior to joining Stanford. When you did see, when New York did report its several cases of MISC in the beginning, and also just if you have any other additional thoughts on the initial workup and how far to go for every patient and that kind of, yeah, any thoughts on that?
Sure, I'm more happy to. Yeah, so I actually started at Stanford in June. So before that I was in New York, and we were there in that time where COVID started hitting, and initially there was dead, no patients in the ED. And then all of a sudden we started getting this influx of all these patients and concern for MISC. And truth be told, we didn't know what we were doing. And we were working up all these patients and getting labs on patients that we normally never did in kids, only in specific situations. And then what do we do with these lab results? And what do we have to be concerned about or not? And it was more, I guess, a reactionary phase in which I think as a program there, we decided to quickly make a pathway, and we were doing these comprehensive workups on everybody. And then since then, things have changed. I actually spoke to some of my colleagues, and now they've kind of gone the other way and have been very selective of who they're doing the workup, if in case they look ill-appearing or they have a high suspicion for MISC. Just because we were doing such a comprehensive workup on a lot of these kids that were being discharged really quickly from the hospital. One of the take-home points I had from that initial period in New York was that a lot of times what really made us get the diagnosis was the vital signs. The kids looked great. We had a couple kids that they were about to be discharged, and luckily we did our thorough workup and then our vital signs of discharge, and we would find that they were cardiac, or a couple of times they were still hypertensive. And that's what made us not discharge them and then kind of investigate a little bit more. So I would say the biggest take point now, and we have more information and whatnot, is it's the vital signs, making sure that you can always repeat those vital signs before discharge so you don't miss anything, but then also having that close follow-up. As for this patient now, I mean, it's the question, how much do we do? how much workup do we do and whatnot. So in RED, I asked some of my colleagues here at Stanford in the PTD, and we don't have a set like pathway really. I mean, we have the LPCH one and we kind of look into it and whatnot, but there's not an agreement of what we're all going to do. And there's some that we do a workup for all these kids if they have a concern for MIC. Personally, I tend not to work all these kids up. If they look well, their vital signs are normal, and I can establish close follow-up, then I tend not to do a full workup. But then again, it depends on what my overall differential is going to be as well. If there's a large differential, like in this kid, if I'm concerned that he had appendicitis, because I believe the second time he came in, he was having pretty significant abdominal pain and palpation, I may go down that route. And by getting some of those labs, and then it might lead me going to the workup of MISC. So I think overall, for me, my take point is the vital signs, and then also, I guess it's to your own discretion as to how much of the degree of workup that you do and what stepwise progress you do for it.
Thank you. Vitals are vital. So, and Dr. Kache, there's a question from the audience. Can you talk about balancing fluid overload with hypotensive shock in the setting of his impaired cardiac output and hypoalbuminemia?
Yeah, I think that's a great question, and actually ties in nicely to what Dr. Schwenk was saying earlier about how we fluid resuscitate these patients. And the truth is that there's been a transition in how aggressive we are in fluid resuscitation in sepsis patients in general. And some of that work started before we even started having the COVID pandemic, but especially afterwards, there's been a lot of insight into the impact of aggressive fluid resuscitation and how that affects their overall respiratory status. And so in these patients, as I'm sure all of you recall, for sepsis patients previously, we would say 20 mLs per kilo as quickly as possible. If they're in shock, all the way up to 60, and trying to do that within 60 minutes. And sort of now the thought process is that you really start with a more ginger dose of fluid resuscitation of 5 to 10 mLs per kilo, and maybe doing that over 10, 20, 30 minutes. Because yes, you can have someone that's hypotensive, and that is of concern and can be a late finding in a pediatric patient. But if you have a patient that's hypotensive and not decompensating, as in this patient, for example, who was sitting there and actually to some degree was able to communicate with our transport team, how aggressively we fluid resuscitate that patient really changes, right? And we also have found that the patients that are more aggressively resuscitated, certainly in COVID, but also in septic shock early on, may have a greater degree of pulmonary findings, and so therefore may require more respiratory support. So I think as a person that's working either in the emergency room or in the general pediatric ward, if you have someone whose vital signs are abnormal, they're tachycardic, they're starting to be hypotensive, there's lots of good reason to be ginger in your fluid resuscitation. So thinking about doing that 5 to 10 mLs per kilo over 20 to 30 minutes and seeing how well they respond rather than slamming in that 20 mLs per kilo quickly. And as I had mentioned earlier, of thinking about initiating inotropes on these patients if they're not responding to those fluid boluses for you. And even the sepsis guidelines now say you can initiate epi or neurepi through a PIV and don't need to have a central line in place in order to start the inotropes, and can do that until the patient is transferred to an ICU. So I think for all of those reasons, to think about being ginger with the fluid resuscitation and doing it over a longer duration of time, I would say. Hopefully this answers the question of the person that had put it forward. So.
Thank you. There's another question about the difference, if you can help them understand the key differences that define MISC from Kawasaki, especially incomplete Kawasaki, and how care may be different in these patients who are COVID positive. I can open it up to whoever would like to take this first.
I'll give it a try in terms of.
Yes, please.
So there are certainly a lot of similarities, but as Dr. Matthew mentioned, Kawasaki patients are tend to be younger, and they also are more often from Asian background, whereas Misc patients are older, and it's seen more commonly in Black and Hispanic children. And as Dr. Schwenk mentioned, these patients, the Misc patients, have more often the GI and neurologic symptoms rather than the other clinical presentation that comes with Kawasaki's. And cardiac dysfunction, as well as presenting in shock, is also more commonly seen in Misc. The Kawasaki patients might also present this way, but it's only seen in 5 to 10% of the cases. And last, there are some laboratory features that are different in Misc versus Kawasaki's. Misc patients have lower absolute lymphocyte and platelet counts. They have higher ferritin and D-dimer levels compared to Kawasaki patients, and they also are a lot more likely to have elevated BNP levels. So that helps us differentiate between those two groups, but I'm happy to get more input here.
Thank you, Dr. Tierney. I think that is very helpful. Dr. Schwenk or Dr. Gerstbacher, do you have any additional thoughts?
I was going to agree with everything that's been said. I think those are all really helpful when you're trying to distinguish the two. I do think it's important to realize that there's a very broad spectrum of presentations for patients with Misc. There is a cohort of patients with Misc who have a lot of features that overlap with Kawasaki disease or atypical Kawasaki disease. And then there are other patients with Misc who do not share all of those features. And trying to distinguish these things and tease them out can be really tricky. I am not a rheumatologist, but we are often called for Kawasaki disease, atypical Kawasaki disease, and I think these things are really nuanced. At the end of the day, the first line treatment for both of these conditions is really IVIG. So you have a little bit of an insurance policy there in terms of the management of these patients. But as Dr. Tierney said, there are some clues that can help you when you're trying to distinguish which of these entities you're dealing with. And so you sort of start broadly, you make sure that you have all of those in your differential. And luckily, the management actually tends to align pretty similarly. But Dr. Gerstbacher may have additional thoughts as well.
Yeah, I agree. That's the point I would make too, is just there's significant overlap, and some of the features that point you in one way or another could be the age, the degree of elevation in the labs, but luckily the treatment is similar in the early stages. So,
Rajni, can I just follow up a question for these guys? Do you think that we will learn more about Kawasaki disease because of this? And I know prior reports have suggested, I think the number in my head is about 30% of Kawasaki disease patients test positive for viruses, but that we don't look for antibodies. We look usually for an NP swab and a viral respiratory panel. Do you think that what might we learn about Kawasaki disease because of this? And might we start thinking and be more convinced that this is a post-viral phenomenon pretty universally?
Well, it's been 4 decades going, and we still don't have a single cause for Kawasaki's. But it could be the silver lining that we get to learn more about what might be triggering Kawasaki's. So far, most of us do believe that it is Kawasaki's is a syndrome that is just a response of a genetically susceptible person to a post-infectious trigger. That's kind of the more common belief. But yeah, that COVID might be the reason we get to learn more about it. Although I'm not sure that they have necessarily a very common path. I would love to hear Hayden and Dana's thoughts about that.
I guess I would say it does seem like there's something unique about the SARS-CoV-2 virus, right? And I think we're not quite sure what it is about this virus that seems to trigger Misc. In preparing for a question like this, I kind of dug around the literature a little bit, and others who are smarter than me may have additional thoughts. But, there's these theories about the SARS-CoV-2 spike protein actually being almost like a super antigen, similar to the kinds of toxins and things that get produced in patients who have streptococcal toxic shock. And that this just really, leads to activation of your T cells and release of a lot of cytokines in a very hyperinflammatory state. And so maybe there's something unique about SARS-CoV-2 that's triggering all of that. I do think this has caused us all to think a little bit differently about Kawasaki disease and ask questions that I had never really thought of, which I think people have already alluded to, right? Which is, we don't usually check a pro-BNP or a troponin for patients with Kawasaki disease, but maybe if we did, we would see a lot of the same things we're seeing with Misc. Again, Dr. Gerstbacher and Dr. Tierney and others who have more experience with Kawasaki could elaborate on that and whether they have additional data. But I think it is at least leading us to re-examine Kawasaki disease, even if we're not still yet able to come up with a unifying explanation for its etiology.
I would just add that there is, sort of emerging data to support that super antigen theory in stimulating the immune system for these like exaggerated hyperimmune responses with so much inflammation. I think that there's more credence to that, and it's still, sort of being elucidated, but I don't know how true that will ring for Kawasaki's, because it seems that there is something unique about SARS-CoV-2 that triggers that type of a response.
Thank you. And I think if any additional thoughts on how confident are we that these labs point towards MISC versus another process? Typically, we don't do these labs for all patients. And so so the question is, how are these specific in any way for MISC?
I don't think there's a lot of specificity. I think there's significant overlap if you're just looking at the labs. But I mean, we're taking a big picture look at the entire patient. We're considering the epidemiologic history that we have. The clinical presentation, I think, can offer some clues, even with things like toxic shock, which may, even by lab values, look relatively similarly. The presentation, even if it's subtle things like the dermatologic features, which it'll be interesting to hear your dermatology colleagues next week or whenever that discussion is. But I think to answer the question, they're not specific. I think it's really putting all of these pieces together to develop sufficient supportive evidence to make that call, but others can weigh in.
Yeah, I would definitely agree with what Hayden is saying. I think it's really difficult to say that based on these set of labs that you are definitively going to have Misc versus not. I would say this is where the entire picture of the patient and discussion with your colleagues and your consulting physicians becomes really important. And so looking at the overall history of the patient, right? They have exposure to COVID 3-4 weeks ago. And so then now they're coming in with these persistent fevers without any other clear source for it. I think the case that you picked is a really great one. And in the pathway, what we did was specifically separate out tier 1 versus tier 2 labs, because as Guillermo was pointing out, you don't want every kid that shows up in the emergency room to get this whole big swath of labs. So get the initial tier 1 labs. And if there's things that are concerning on the tier 1 labs that are pointing you towards MISC, and you don't have another clear explanation for this persistent febrile illness, you have someone that has more GI symptoms than what you would expect for Kawasaki's, for example, or isn't quite in the age group, then you do the tier 2 labs, you treat them for sepsis, you continue to monitor these labs and then say, okay, nothing else quite explains this. And now I have vital signs that are concerning, or I have vital signs that are concerning to begin with. I would say that it's not easy to put our finger on one thing and say, for sure, this is what gives this patient MISC versus not, so.
We are on the hour, but quickly, Dr. Kache, any thoughts on the Lovenox, use of Lovenox, because there's a question about that. And I have another question about use of only steroids versus IVIG and steroids as well. So Dr. Schwenk and Dr. Gerstbacher, you can weigh in on that. But Dr. Kache, if you can go on the Lovenox.
Sure. If I'm assuming people can access your slides or get access to the pathway that we made. And just for people to be aware, on the third page of this pathway, we actually had 2 of our hematologists weigh in on when to use Lovenox on these patients. And it turns out that actually the risk of having coagulation problems on the younger patients is much less than it is on certainly adults. Part of it obviously has to do with the adults. They're presenting with the initial respiratory illness versus with MISC, we're looking at it as a post-infectious dysregulated inflammatory process. Having said that, there's recommendations on here that basically go through when to prophylax a patient, how much you're going to give them for the Lovenox, and if you have someone that actually has concerns for true clot, that you're going to put them on treatment doses of Lovenox, and what target 10A levels you should, or anti-10A levels you should aim for on those patients. So all of that is laid out on the third page of the pathway. Hopefully that answers the question.
Thank you, Dr. Kache. So there's a question about when there's IVIG shortage, why can't we just do steroids and see if the patient gets better?
I can try to take a stab at that one. So I think my reluctance to doing that at this point would just be that our experience is largely by using IVIG upfront and then using steroids for more severe or recalcitrant cases. And that's really just experiential. I do think there are reports in the literature of patients who've been treated with steroids alone. And so I don't think that that is off the table as a consideration. If I were stuck or in a situation where there was not access to IVIG, I think it would be totally reasonable. And in fact, this patient got a dose of steroids kind of en route to the hospital, before they got started on, or before they received any IVIG. So I think it's a really interesting question. I guess the only thing I can say is that, experientially people have had success, and we know that the outcomes are actually really good for Misc patients with IVIG up front, and that would be the only thing that gave me pause. I'd probably call Dr. Gerstbacher to confirm, but she may have additional thoughts.
Yeah, I mean, I think that there definitely are case reports, especially as there's more of an IVIG shortage of using steroids alone, especially for some of the patients that might be a little bit on the more mild side. But really, it's just been our experience that using steroids and IVIG together has the best response.
Well, I think we've tackled most of the questions. Dr. Schroeder, do you think we did well? But clearly, this is an interesting topic with a lot of very good questions that came through. I'm very grateful to our panelists, all of you, for so busy, but taking your time to come and present to us and the audience. And thank you to the audience for sticking around. We'll see you all next week.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.